Our injury scenario for lab 5 with the anterior lower leg. Usually our injury scenarios are referring to previous labs. So this is going to be back from material we covered in lab 4. But our injury scenario, we've got a tennis player complaining of posterior lower leg pain. We ask what happens, and they say they were late getting to their match yesterday. It was colder, wet day, and they didn't get to warm up properly. They just jumped right into playing, and pretty quickly into the match they felt a sharp twinge of pain on the left lower leg posterior. So we asked where specifically is the pain, and they point right kind of at the transition from gastroc to Achilles tendon, a bit more so on the medial side. If we ask them to rate their pain out of 10, they'd give it a 3 out of 10. And then we ask them what is their 10 out of 10, and they say they've dislocated their thumb in the past. That was the worst pain that they've ever experienced. Better and worse. So this happened yesterday, and they said last night they iced it, which made it feel a bit better. And they took some ibuprofen, which also decreased the pain a bit. For worse, they found that walking uphill, walking upstairs, first few steps of walking, if they've been sitting, it felt quite stiff and painful, and then it seems to ease off a little bit. Any prior injuries, they would say that they haven't had anything like this in the past, but in general they have tight calf muscles that they've noticed for a long time. Snap or pop, they report that they felt a bit of a twinge, so maybe a light pop when the injury did happen. Medications, other than the ibuprofen, they're not on any other medication. Allergies, they just have seasonal allergies, so nothing significant there. And footwear, not too often that this is relevant for an acute injury like this one is, but they report that they had good, proper tennis shoes on, but the court was a little bit wet while they were playing. So that's it for our history. Next, we move on to our physical exam, and just like every week, we start off with our observation. So first, we'll have this athlete just standing, and we'll look at them while they're standing. So with our assessment, observation, we'll look at their lower legs while they're standing. We can get them to squat, and we see an average amount of pronation, twist from side to side, same thing, an average amount of pronation and supination depending on which side they twist to. If we look at them from the back side, we can see some redness and swelling in the area where their pain is, maybe even a tiny bit of bruising. And then we'll get them to do some functional movements. So our gait, get them to walk out 10 steps and walk back. There's a noticeable limp when they try to push off with the right leg. We can ask them to go up onto their tiptoes. They can do so on both sides, but there is some discomfort on the right hand side. And then, so that's weight-bearing plantar flexion. To assess our weight-bearing dorsiflexion, we can ask them to do knee to wall. So touching knee to wall, keeping heel on the ground, trying to get toes as far back as possible. On the left, the injured side, we'll say the measurement is 8 centimeters from the wall to the tips of the toes. On the right, the measurement is 11 centimeters. So significant difference from side to side. After observation, we'll move on to our range of motion. And we always start with active range of motion first. And the movements we're primarily interested in is plantar flexion and dorsiflexion. We can do our inversion, eversion, and toe flexion and toe extension as well. First toe and 2 through 5 flexion, 2 through 5 extension. Okay, so active plantar flexion, they have full range of motion, but we'll say they have mild pain. So the plus sign indicates pain, and they have a mild pain, so it's just one plus sign, and the range of motion is good. Dorsiflexion is decreased on the injured side, and at the end range they have moderate pain. Inversion actively okay, eversion actively okay. First toe flexion, range of motion is good. Extension is decreased a little bit due to pain. Toes 2 through 5 flexion is good. Toes 2 through 5 extension decreased just a tiny bit due to pain. So that's active range of motion. Passive, we're moving the body part for them. And with their passive range of motion, now plantar flexion is totally fine because we're moving the joint into plantar flexion for them. Dorsiflexion is still decreased, and they have moderate pain when we bring them to the end range of dorsiflexion. Inversion and eversion is okay. First toe flexion and toes 2 through 5 flexion, no problem when we do it passively. First toe extension is okay, but they have a little bit of pain because we're putting stretch through the deep posterior compartment, and same thing with toes 2 through 5. Range of motion is good when we do it for them, but they have a bit of pain. Lastly, we move on to our resisted range of motion or strength testing. So we want to strength test in the mid-range of their movements, where the muscle fibers overlap the most. That's where they should be the strongest, and we want to strength test them isometrically. So we'll ask them to hold their foot in that position. Don't let us move it in different directions. So for resisted plantar flexion, there is some weakness, 4.5 out of 5, and they have moderate pain when we test plantar flexion. Dorsiflexion, 5 out of 5, no pain. Inversion, 5 out of 5, no pain. Eversion, 5 out of 5, no pain. First toe flexion, we'll say, is full strength, but they have a little bit of pain. First toe extension, 5 out of 5, and no pain. Toes 2 through 5 flexion, full strength, 5 out of 5, a little bit of pain because they're engaging the muscles of the deep posterior compartment, so near where the injury has occurred. And for toes 2 through 5 extension, 5 out of 5, and no pain. After our range of motion, we move on to ligament stress tests. Now, we're only concerned about ligament stress tests or an injury to the ligament when it's acute traumatic injury, which, yes, this is an acute traumatic injury, but where they pointed to their pain, it's about halfway down the posterior lower leg. So we know there's no ligaments in that area. So we're not worried about any ligaments having been sprained, but we are worried about muscle and or tendon having been injured, so a strain. So since we don't need to do ligament stress tests, we can move on to our special test. Okay. And for special tests, we can do our gastroc and soleus length test, and we could do our flexor hallucis longus length test as well. Okay, so to do gastroc length, with the person seated with the knee extended or the leg stretched out in front of them, we'll do passive dorsiflexion, and we compare side to side, injured side to non-injured side. So on the left, the injured side, we'll say they had 5 degrees of passive dorsiflexion. On the right, they have 10 degrees. So again, noticeable difference from side to side. If we want to check the soleus length, now we have to flex their knee or bend their knee, and again we'll do passive dorsiflexion. Now when the knee is bent and we're testing soleus, the left is 10 degrees and the right it's 10 degrees as well. So normal side to side. So we're primarily concerned that the gastroc is the muscle that has been injured. Flexor hallucis longus length test, we're just passively extending the big toe, and we'll say that it is equal side to side. So we'll get, say, 55 degrees of first toe extension on both the right and the left. So range of motion is equal. They have a little bit of discomfort as we do so. So we're putting stretch through the flexor hallucis longus. They might have strained that muscle a little bit as well. After our special tests, we move on to palpation. And so we want to palpate the gastroc, soleus, because it's deep to the gastroc. We can only kind of get at it on the very medial edge, right behind the posterior medial tibia. So when we palpate the gastroc, both with the medial and lateral heads, but more so with the medial head right at musculotendinous junction, they have moderate pain, reproduces the pain that they've been feeling the last few days. When we palpate the medial edge of the soleus, no discomfort there. So our diagnosis, we can palpate down along the Achilles tendon as well. They have no discomfort over the Achilles tendon. Diagnosis would be gastroc strain. And since the findings were primarily moderate with pain and with our strength testing, then we indicate it's a grade 2 strain of gastroc. Pain's more on the medial side, so we could say medial head gastroc strain grade 2. In terms of our treatments, we'll begin with our police, and we found that that there was a bit of a limp, and our general rule is if somebody's limping, then they need additional support. So crutches, maybe a cane, so that they're not causing biomechanical adaptations up through the lower leg into the knee and the hip. That doesn't want to erase. Okay, so for treatment, police protects, only put as much stress through it as they can tolerate. The optimal loading, that's where the crutches or cane may come in. As long as they have a limp, they need additional support. And their ice compression elevation. As pain is settling down, then we can weight bear through it more. We're going to work on our range of motion, active assisted, so using a towel to help pull the ankle into dorsiflexion. We want to avoid sharp twinges of the pain because that indicates that we're just tearing apart those collagen fibers that the fibroblasts are laying down. We could use stationary bike. We could push our foot into the wall, getting into our strengthening first with isometric, and then when we can push into the wall 10 times 5 seconds for plantar flexion, move on to isotonic with stretchy bands resistance, and then finally our eccentric loading. And so the video that we including for eccentric loading, you would do that with the patient. We don't want to be too aggressive with the stretching initially, so it's probably a couple of weeks that we'll wait before we're doing a lot of stretching for our range of motion, and also with this deep soft tissue massage in there, waiting a few weeks for that. As we're leaving our strengthening and the eccentric loading and more plyometric and explosive movements, we'll be doing our balanced proprioception, 2 legs, single leg, eyes open, eyes closed. We can add in perturbations or tossing a ball with them to try and knock them off balance a little bit. Then we'll move on to our running progression, pool running, deep ends, shallow ends, softer surface running, harder surface, and then we gradually introduce cutting and movements as well to challenge them further. And then our return to sport progression, whatever sport they are, we gradually reintroduce them. Light drills, harder drills, light contact, full contact, scrimmage, and return to sport. They may want some additional support for the lower leg, limiting ankle dorsiflexion. So we may do our Achilles tendon tape job if they feel like that helps. Okay. Possibly even a compression wrap over the distal gastroc. And if that's helpful, then the compression sleeves that they can buy and put on themselves. So that's our injury scenario for posterior lower leg, and we had an acute gastroc strain.